Hi, I'm Weijs, and this clip is on protein requirements in health and disease. This is the longest clip contributing to the lecture on energy and protein requirements in health and disease. And let's go for it. When we look at severely ill patients, their physical recovery can take a very long time after hospital or critical care discharge. What you can see here on the x-axis is 0, 1 and 2 years. There is some sort of recovery, and then even after 5 years the patients do not reach the level of their peers in the recovery. So severe disease can result in a very long-term physical disability. And with nutrition and also with exercise, we try to improve this situation. In critical care, but also in hospital wards, at some point we also have to think about muscle mass of patients. This is a nurse from California during COVID period, and the picture clearly tells you that muscle is being lost dramatically during a period of COVID disease. So muscle loss. And I'm sorry, there will be some Dutch slides in this lecture. What you can see in this picture is muscle loss on the y-axis and age on the x-axis. And during lifetime there is a natural loss of muscle mass, muscle strength and physical function. This is not especially a linear function, but it is driven by incidents, and incidents can be, for instance, a COVID period, a COVID disease, but simply lying on bed for a few days can be a very much a contributing factor. With age, there is a muscle loss of 0.2 kilograms per year, so that does not seem so dramatic, but it adds up during the years. But in hospital, it can increase to 0.2 kilograms of muscle loss per day, and in critical care, even to 1 kilogram in the acute phase per day. So muscle loss can be dramatic, and it has repercussions for physical function and self-reliance. So keeping away from this red line where invalidity and non-self-reliance occurs is really something to strive for. So low muscle mass here, this is hospital mortality on the y-axis. In blue there is normal muscle mass patients diagnosed based on this CT scan at L3 level, based on the red area in this CT scan. And we also here have the patients admitted to the ICU with low muscle mass in red, and you can see that hospital mortality is much higher in this last group. So low muscle mass at the start of your ICU period is really a bad predictor for your outcome. And then during ICU it's even worse because muscle is being lost dramatically. Here you can see measured with ultrasound on the quadriceps muscle in the upper leg that 18% of the muscle can be lost in 10 days. And then also the diaphragm, which is the respiration muscle, you could say. Fibers of that muscle are also experiencing atrophy, which you can see here in the lower bars, and this is about 25% reduction in cross-sectional area of these muscles. And if you look at function of diaphragm fibers, the contractile weakness is shown here in the lower maximal absolute force of these fibers under these specific conditions. So fibers can produce less force for using your lungs. Now, what is actually being lost? This is a picture that has been constructed by measuring skeletal muscle protein or muscle mass loss based on muscle mass loss based on DEXA measurements, and total body protein loss is being measured by in vivo neutron activation analysis. So a very specific method that is still being used in New Zealand, but there are only a few in the world to be used. So this is very specific information. And if you really look at the first 5 days and the loss in protein during these 5 days, then the total protein loss is actually almost equal to the skeletal muscle protein loss estimated from DEXA scans. So really the muscle loss is also protein loss from your body, and really extrapolates to protein nutrition in that sense. So these losses can be really dramatic. So what are contributing factors to muscle loss and not moving around? Just so no activity, inactivity contributes a lot. In this experiment, normal, healthy, young individuals remained in bed for a week, and they experienced a loss of fat-free mass of 1.4 kilograms and muscle loss at the upper leg level of 3.2%. So muscle can be lost by just staying in bed, and this is therefore not exclusively due to the disease. So you have to understand this is a normal physiological situation, and this is mainly due likely to the early development of insulin resistance by inactivity. So the more severe the inactivity is, the more the insulin resistance is developing. And this is a slightly more severe situation where the right leg is being immobilized in this way in the picture for 14 days, and here you can see the percentage change in cross-sectional area of the muscle, and here you can see 5% loss in the immobilized leg versus no loss in the non-immobilized leg. So this is very, very important factor. Now if we look at fractional synthesis rate, which means protein synthesis, then in the starved state, of actually the overnight fasted state, you see that there is less protein synthesis in the immobilized leg than in the non-immobilized leg. But also after providing nutrition, after providing protein, you see a much smaller response in protein synthesis. And that is really dramatic. If protein synthesis cannot happen and it cannot be stimulated by protein, then we have quite an amount of what we call as an anabolic resistance. And it doesn't mean that we cannot overcome this, but it really depends on the level of protein feeding whether we will exceed this level of anabolic resistance. So just to dive a bit deeper into this, this is called protein turnover, and this is protein intake, and when we take protein in, our goal is to have those amino acids that come from digestion of protein. We want to build those into body protein and muscle protein. But there are quite a few factors like age, disease, and especially inflammation is an important factor, inactivity, and also nutrition, including nutritional factors as overweight and obesity, but also the level of protein we feed can influence this process. So we have some factors that are not really helping here in getting the protein that we eat into the protein that we need. So if we need muscle protein synthesis here in level 5 in red, so the protein we need, then we also need amino acids in level 4 to be taken up in the muscle cell. And if this doesn't really happen good enough by, for instance, insulin resistance, then we do have some inhibition here. The next thing is that amino acids in level 3 have to be delivered by the blood and blood flow to the legs in order to be able to be taken up in the muscle cell. And if blood flow is not going to the legs by, for instance, inactivity, then we have an inhibition here as well. And the next level, level 2, is amino acid absorption in the gut. And if this process is inefficient, then we have an extra level of inhibition there. And all these steps, phases, and processes together may result into a larger anabolic resistance. And we know from studies in sports and in elderly especially, that if we want to succeed in having this protein synthesis, it will actually happen under different circumstances, but we then have to provide more protein. If we provide more protein at the upper part of this picture, then we are able to overcome this anabolic resistance and have the same level of muscle protein synthesis. And we also can manipulate which kinds of protein we provide and how we divide them across the day. Now, if we look at the anabolic signals in the muscle cell, we have nutrition and we have exercise as important factors, but especially insulin is an important anabolic factor. But if we just look at critical care patients, we have insulin resistance, we have no physical activity, then we can imagine that other nutritional factors, like for instance the amino acid leucine, can have a major impact on the mTOR pathway that is in fact the stimulating pathway to muscle protein synthesis. We still have to demonstrate a lot of this, but here the substrate leucine as an amino acid actually becomes a signal more than a substrate. What you can see in this picture is measured in very ill patients lying in a hospital, in fact critically ill patients that have muscle protein synthesis being measured at the 2nd week and the 5th week. And what you can see here is that protein synthesis actually develops. So at week 5 there is a normal level of protein synthesis, and at week 2 we have a very low level of protein synthesis, which actually demonstrates the anabolic resistance which these patients experience. What you see for protein breakdown in the middle panel, there is virtually no difference between the two situations. And in the right panel, you see that at 2 weeks there is actually muscle loss, and at 5 weeks there is actually no muscle loss anymore by stimulating protein synthesis and by re-establishing the balance between protein degradation and protein synthesis. This is a a signal of recovery. So at week 5 there really is some hope for recovery. There is no net loss of muscle anymore, but at the same time a lot of weight and a lot of muscle has already been lost in the weeks before. So it is a sign of recovery, but it still is a very dramatic situation for the patient in week 5. So the question is, does protein actually help in the ICU? And muscle loss, in fact, provides amino acids, and one of the reasons for that is that muscles are not, the skeletal muscles in the legs, for instance, are not being used at this moment. They are lying still in bed, and they are inactive due to bed rest. So what actually happens by protein turnover is that they provide amino acids to the system, to your body, and the system uses it for processes that are related, for instance, to organs. So producing other proteins, providing amino acids to the immune system, which is very important for survival, and much more important at this moment than the muscles for activity, because the muscles are not active. So our question, of course, is, can protein nutrition now provide amino acids and then keep at least some of the amino acids in the muscle, probably not all, depending on the level of disease, and provide other amino acids to these very essential functions on the right side. What do guidelines say? This is the newest guideline that is the active guideline at this moment, and the only recommendation we have is that the level of protein should be at least 1.3 grams per kg protein equivalence, which is 1.2 grams per kg for protein. However, the grade of recommendation is 0, so the evidence is really absent on a randomized control trial level. However, the consensus on this topic is really very high. So we all agree that protein nutrition in the ICU is very important, so for critical care, and this is also true for other patients groups in general. However, there are no real recommendations on how to supply it and how fast we should deliver this. Now, what do we know about this? These are patients in the first week of a critical illness, so they are still very ill, and what this group from Sweden, from Karolinska in Stockholm, has shown in this picture is that by increasing the amino acid and protein feeding in these patients, there is a response, and now this is a whole body response of protein balance, is really almost linear. And this means that during critical illness we can actually go from a negative protein balance to a positive protein balance, and not just by accident. I think that is a level of protein feeding that is actually above 1.2 grams of protein per kg per day. So this is really the lower level I think we should feed these patients, which is in agreement with the guideline. Now, we don't have much evidence from randomized controlled trials, but these are 2 randomized controlled trials that have looked at the short-term effect of providing a higher level of protein or amino acids. To the left side, the amino acid level went from 0.8 grams per kg to 1.2 grams per kg. Now, this is a fairly low level and also a small window of opportunity between the 2 groups. And on the right side, a level of the same levels of protein have been provided in as whole protein, not as amino acids. Both studies, rather small studies with 60 patients, 120 patients, do actually show positive results on muscle loss. So the less muscle is lost and the function is retained in a better way. And in fact, there is a third small trial published now. However, this is on a short term, and this is just muscle, but what about outcome? Now, this is an analysis we did some years ago in the Amsterdam UMC, showing that hospital mortality on the y-axis versus protein intake of the patient groups showed that the highest level of protein intake, above 1.2 grams per kg, was associated with the lowest level of mortality. But we have to add to this that we first had to exclude sepsis patients, which didn't actually show a response, especially on the high levels of protein intake. And we also had to exclude patients that had received energy overfeeding. And as you've seen in the other clip, energy overfeeding can actually inhibit, can be detrimental for the patient. So after excluding these patients, we got a very, very positive signal from protein intake. This is still observational data, but we can state that left to the black dotted line, there are patients that have low intakes because of several different reasons, but to the right, these three groups all have adequate nutritional intakes. So the protein level, and we can see that in the next slide, is actually the reason for the effect that we see. So we provided in this group actually 25% more protein than in the second group in this picture, and this means that the protein, while adequate feeding has been supplied, is really probably making the difference. But again, this is observational data. Now, there is a randomized controlled trial that was feeding high levels of amino acids just by intravenous infusion. Such a high levels that I thought, well, this is not going to be a nutrition study, but a pharmacological study. However, if you look at this picture, then the protein intake was really roughly 1.7 grams per kg, and that is still to be called a physiological level. However, the 90-day mortality was not different between the two groups, with or without the amino acid infusion. However, in the next slide, we can see that they did a post hoc analysis for those patients that had still a normal kidney function, and this group is actually in both arms, so with the amino acids and without the amino acids, 80% of the original trial. And if you compare those patients, you can see that amino acid infusion, a simple amino acid infusion, results in a very dramatic difference in mortality, 90-day mortality in this group. So this really, although this is a post hoc analysis, really demonstrates that a lot more is going on than has been demonstrated up to now. This is outside of the ICU. This is just a regular hospital wards in a hospital in Switzerland. However, this is the largest trial that has studied the effect of dietetics on outcomes in inpatients. The EFFORT trial that has rather recently been published, and for the combined outcome, that is 30-day, a combination of 30-day mortality, ICU admission, hospital readmission, and complications, and decreased functional state, you can see that by providing adequate dietetics, there is a very significant improvement in patient outcome. So in this case, I have to state that it's not just protein but also energy. So is this the same for all patients? We have to understand that malnourished patients usually benefit more, which is logical. And this analysis, which I did with people from Harvard in Boston, they had a population of 800 ICU patients that had actually survived the hospital. So they were discharged from the hospital. We looked at how much protein they actually received in the period in the ICU. And what we saw in the 90-day post-discharge mortality, that there is a 17% lower mortality rate in those patients with the higher protein intake. And the dietitians in the ICU also established whether these patients were malnourished. 60% of this group was in fact malnourished. And if you look at 90-day mortality in this group, then the extra protein actually resulted in 30% less mortality. So again, this is observational data, but rather a striking result that shows that malnourished patients especially benefit from extra protein during critical illness. And this is our latest analysis that is published in Clinical Nutrition now on 740 patients that we also had CT scans of the L3 level, which we use for muscle mass assessment. Now, we divided this group into patients with normal muscle mass at the start of the ICU admission, which is about 40% of the group, and a group with low muscle mass, which is 60% of the group. And half of this last group has low muscle mass but also a low muscle density, and this is an indication of low muscle quality. So we have three groups that we will describe in the next slide. The patients with normal muscle, and you can see here the patients receiving more than 1.2 gram protein per kg in orange. There is not a big difference, at least it's not a significant difference. The patients with low muscle mass have a very significant difference in 60-day mortality, and patients that also have a low muscle quality, low muscle density as it is measured, you see a dramatic difference. And these analyses are not just based on protein intake, but they have been adjusted for disease level, so a Patches 2 score, which is not perfect, but it's still an adjustment for disease, and they have been corrected for the level of energy intake. So we think that even the early protein in the first days, which is a lot of discussion about in world literature, is beneficial, but we still have to do prospective studies in order to show that this is really helping outcome of patients. Now, how does training help in this system? How can protein and training cooperate in remaining the muscle? Well, as I just showed in the picture, a protein can be provided from exogenous sources, providing amino acids for building into the muscle, and training is actually sensitizing the muscle in order to have this muscle protein synthesis being organized. And then the logical thing is to provide amino acids as substrates for the muscle. And by providing an extra amount, the suggestion is that there is enough amino acids for both survival of the critical period, as well as maintaining at least some of the muscle mass. Now, in general, there are quite a lot of studies being done. This is just one example. measuring muscle protein synthesis, providing protein here in the form of steak that provides a large protein quantity at the same time. So it's one meal of 30 to 35 grams of protein. And what you can see is that just by providing this protein, there is a higher level of muscle protein synthesis. If you combine this by exercise and strength training, then the response to this protein is actually even higher. So the combination of the two always in all these experiments results in higher response in muscle protein synthesis, and therefore it is recommended to combine these two. And I show you that inactivity relates to muscle loss, and activity or active training results in muscle gain. However, active strength training is a bit difficult in very ill patients, so it's not that easy, but at least we can use it in some way. What you can also see in this picture is that there is no difference here between young in black and old in white, and this is actually due to the fact that 30 to 35 grams of protein has been given, because if this had only been 15 grams of protein, then the response in the elderly would have been lower. So this is a demonstration in the sense of what I showed earlier or suggested earlier, that that you can actually have the same result in muscle protein synthesis, at least when you provide enough protein to overcome the anabolic resistance. Can this be applied in frail elderly? We are outside of the hospital. This is elderly in society, however, in a frail state. Can we help them to remain some of the muscle mass or even gain? Well, just by supplying protein in this study of half a year was not resulting in more lean tissue mass. However, in this study where the same amount of protein, 2 times 15 grams, so 30 grams of protein as a supplement was provided, but in the right hand trial actually combined with strength training, and then you see an increase in lean body mass, and this is actually very beneficial in the frail elderly. But still, it takes a lot to have this training going on for half a year. Now this is a study which we did in overweight older adults losing weight. So they had a hypocaloric diet and a 3-month training program, and in the black bar group they actually had a protein supplement, and the protein supplement, what you can see here, has resulted in muscle gain, but the absence of the supplement resulted in muscle loss. So this means that hypocaloric feeding and training resulted in loss of muscle mass, while we can preserve muscle mass by providing extra protein. This is a more recent study, it's not fully published yet, where we have almost the same idea, but obese elderly, but now with type 2 diabetes, so they are actually diabetic. They are going to lose weight by hypercaloric diet and training, and mixed training of endurance training, strength training, and high intensity training for 12 weeks. And you can see that even after very intensive program, they only gain about 300 grams of muscle. So if you lose 300 grams of muscle a day in the hospital, then training it back needs at least 3 months. So this is really, in that sense, sort of disappointing. The good thing is that the training helped to get rid of the muscle loss in the control group, as you can see here. And this is probably due to a combination of the strength training and the HIIT training. However, we have to understand that 12 weeks, 3 times a week of training is very a large effort for these older people. So if you come out of the hospital, this is really not really feasible to do. On the right hand side, it's interesting that the difference between the protein supplemented group in blue and the control group in red is really much more different, a much larger difference. So we have to really understand that what is being lost from the body is not just muscle. It's more of the lean body mass, and we have to understand that with protein feeding, we are feeding the lean body mass as a total and not just muscle. And what you can see in this picture is that training can do a lot on the muscle portion, but apparently not really on the other portion. So we have to also not neglect this. And this is another study with elderly, but they are living in the community. They are not necessarily obese, but most did in fact have some form of chronic disease. What we did was an intervention during 6 months, or actually measured up to 12 months. The control group was a group of elderly that actually was part of a social program once a week with physical activity involved. The intervention we provided in the red line was in fact a home training program with a lot of functional exercises, so no strength training, functional exercises are not specifically strengthening. It obviously also can involve strength, and this did not result in a full repair of muscle loss, because in the control group it was more than 2%, and this is still more than 1% muscle loss after 1 year. But when we also provided advice on protein very specifically and personalized, then we were in fact able to normalize muscle and maintain muscle mass. So this really is a dramatic difference between the protein and training intervention group, which can just be done at home with normal supermarket products. You don't need special products for it, with a training program delivered by an app, but you still then also have to do some of the work. But this is a lot less involved than going to a sports facility, because for elderly, not all elderly are really going to be able to do that. And this is just an example of the digital, the tablet form, tablet display, and examples of the sort of exercises that is actually part of this training program. Now, to finish this part, is that protein supplement actually improves the effect of resistance exercise on skeletal muscle in healthy subjects, and there is no reason to think that this is not working in disease. Now, a bit of summary in this slide. How much protein is needed? I think in a lot of circumstances, and I started off with the critical care, but I also talked about hospital wards and the situation there. I also talked about elderly and the circumstances. Elderly with chronic disease, elderly with some acute illness, and in all these circumstances we recommend a level of protein intake of 1.2 to 1.5 grams per kg. And this is really aimed to have the best effect on their total body protein level and to remain the muscles where they are, but obviously some loss under circumstances will appear. However, if we really want to attack muscle protein synthesis, so provide protein for muscle specifically, then we should try to provide at least 0.4 grams per kg of protein per meal, which is 25 to 30 grams per meal for a 60 to 75 kilogram person. Now, for a sports person, that is not really a problem. For most adults, this is also not a problem. For elderly in the warm evening meal or lunch, this may also not be a big problem, but for breakfast and lunch, this will not be able. And also, a lot of elderly eat less and less, and mainly due to less activity and less lean active tissue mass, meaning that loss of appetite will result in smaller meals. So it's in a natural way, this is very difficult for elderly and especially for ill people to attain. Now, dietitians very often ask me whether small amounts then still are important, because it's very difficult to have those large amounts of protein at the same time. And yes, we know from studies that also small amounts of protein directly lead to improvement of protein synthesis. However, this is not specifically muscle protein synthesis. So we have to be realistic that if we are aiming muscle protein synthesis, we have to try to provide a fairly high amount of protein at the same time, even if it's just once, and it can also be just a supplement, as long as it's about 25 to 30 grams per meal or supplement. So it can be provided in different ways. If we look at the timing during the day, supplements, as I show here, can be at the moment of breakfast and lunch, but also it can be a pre-sleep snack, but it has to be in the right level in order to be efficient. Now, if you are looking at the combination with training, then it's important to sensitize the muscles before the substrate protein has been delivered. So the sensitization by training has to be before that meal. And then you can start to play what to organize and how to organize it. But these are the options. Maybe especially for elderly and frail elderly, starting training before breakfast is not a good idea, but I leave that to the professionals. Now, I started off with some sort of picture on functional recovery. We don't fully know how we can actually save people and physical function of people for the long term by providing protein in combination with exercise and training. But this is really our long-term goal, and not just for ICU, of course, but because, as I try to explain, this is actually true for all hospitalized and even ambulant patients or outpatients, and this is also true for all elderly in the community that are struggling with muscle loss, protein intake, and especially self-reliance. So if we want to stimulate self-reliance and remaining living at home instead of institutions or hospitals, then we really have to work on this topic. Now, a bit of a summary. I think you have to understand that inactivity, bed rest, disease, all induce muscle protein loss. So muscle loss is also especially a form of protein loss because it's actually the largest container of protein in your body. Adequate protein is therefore important to maintain the muscle and probably also important for survival, although we do not understand all these factors. And this is therefore true both in health, for instance during weight loss, and disease, and even in critical illness. And protein requirements are increased in elderly, in disease, and in sports, and in fact any adaptation process in the body, and this relates back to what I said in the clip on starvation, means that protein requirements are most likely increased in order to help that adaptation to be constructed and to be realized. Okay, thank you very much and see you later.